Efficacy endpoints in oncology, clinical trials define how treatment benefit is assessed. They determine what a cancer study is trying to prove and what a result can reasonably claim. In oncology, benefit can mean several things. A treatment may help patients live longer, may delay disease progression, may shrink tumours, or improve symptoms or quality of life. These outcomes are related, but they are not interchangeable. A trial can show tumour shrinkage without proving longer survival, or delayed progression with side effects that affect whether the benefit feels meaningful for patients. Overall survival, often shortened to OS, measures the time from randomization to death from any cause. It is direct, clinically meaningful, and relatively objective, which is why it is often treated as a strong survival endpoint in oncology. Unlike some tumor-based endpoints, it is less affected by differences in assessment. OS is not practical for every study. Some cancers progress slowly, so waiting for enough survival events can make trials longer and larger. OS can also be affected by treatments patients receive after the study therapy, which can make it harder to isolate the effect of the intervention being tested. Progression-free survival, or PFS, measures the time from randomization until disease progression or death, whichever happens first. It can provide results earlier than OS and may be useful when a treatment is expected to delay tumor growth. PFS depends on careful trial conduct. If scans are delayed at one site but completed on schedule at another, progression may be recorded at different times for operational reasons rather than clinical reasons. Scan timing, missed assessments, censoring rules, and progression definitions all need to be managed clearly. A delayed scan or imaging upload can quickly become an endpoint issue. A longer PFS means the disease has not progressed or the patient has not died within the endpoint definition for a longer period. It does not automatically prove that patients live longer. Reporting needs to keep tumor control, delayed progression, and extended life distinct. Objective response rate, or ORR, is another common oncology endpoint, especially in earlier studies. It measures the proportion of patients whose tumours shrink by a defined amount for a defined period. In solid tumour trials, ORR is often assessed using RECIST, which stands for Response Evaluation Criteria in Solid Tumours. RECIST sets rules for selecting lesions, measuring them, and categorising response as complete response, partial response, stable disease, or progressive disease. For example, a patient may have measurable lesions on a baseline CT scan. The trial team selects target lesions, measures them, and compares later scans with that baseline. A partial response requires enough reduction in tumour measurements, while progressive disease may involve enough growth, new lesions, or progression of non-target disease. ORR can show anti-tumour activity earlier, but it focuses on shrinkage. A treatment may slow or stop tumour growth without enough shrinkage to count as a response. It also does not show how long a response lasts, so duration of response is often reported alongside it. Other endpoints are linked to treatment setting. Disease-free survival, or DFS, is often used after definitive treatment, such as surgery or radiotherapy, and measures time until recurrence or death. Event-free survival, or EFS, is more often used before surgery in neoadjuvant settings, where events may include progression, discontinuation, or death. Oncology endpoints are not only imaging-based. Health-related quality of life can show whether patients feel and function better during treatment, while symptom endpoints can add evidence when tumour measurements do not tell the full story. Symptoms can be influenced by progression, toxicity, other conditions, later therapy, missed assessments, or open-label trial designs, so the questionnaire, timing, missing data rules, and interpretation need early planning. Endpoint choice should be justified before the trial starts. The protocol needs to define the primary and secondary endpoints, how they will be measured, and how missing or incomplete data will be handled. By final analysis, many of these issues are difficult to fix. The endpoint has to be collected in a way that supports the claim the trial wants to make. OS remains the most direct survival endpoint, but it is not always feasible or sufficient on its own. Other endpoints can add useful evidence when they fit the treatment goal, the disease setting, and the data the trial can realistically collect. To learn how Quanticate can support your next trial, email inquiries@quanticate.com or request a consultation through our website. Thanks for watching, and don't forget to subscribe for more practical insights on clinical trials and modern drug development.